From Microbe TV, this is Infectious Disease Puscast, episode 41, recorded on November 8th, 2023. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are you doing today, Daniel?
Well, I'm doing well, but I'm a little suspicious, Sara. There was a whole article about phage therapy, and I was waiting for the episode to be peppered with phage papers. And now I'm curious, are you going to do like some special febrile phage episode? You're saving
I don't
them
have one in the works. I probably just missed it. I do like to grab the phage papers whenever I can.
All right. Well, one of the journals has an entire journal issue just all about phages. So.
All right, there we go. Well, we got lots of good stuff today.
Excellent.
I'm sure you guys know by now, but Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature.
All right, well, we'll start with viral, and remember to listen to This Week in Virology, both the clinical update and the deep dive. And just to let everyone know, this is going to get a double dip. I'm going to talk about this on both. I will star this first article as the most important article this week, the article Intrinsic and Effective Severity of Coronavirus Disease 2019 Cases Infected with the Ancestral Strain and Omicron BA.2 variant in Hong Kong, recently published in the Journal of Infectious Diseases. So for a while, I've been suggesting that whenever we see things improving with regard to COVID, this is a chance to say, wow, those vaccines really were a game changer, instead of thinking that in the course of a few years, this virus somehow got intrinsically milder. Well, here, time-varying and age-specific effective severity measured by case hospitalization risk and hospitalization fatality risk were estimated for all individual COVID-19 case data collected in Hong Kong from the 23rd January 2020 through the 26th of October 2022 over 6 epidemic waves. The intrinsic severity of Omicron BA.2 was compared with the estimate for the ancestral strain with the data from unvaccinated patients without previous infections. And I should sort of say, why are we getting data from Hong Kong? Well, Hong Kong had a particular situation where they were really part of that China zero COVID, so they were not seeing a lot of previous infections. They were not seeing a lot of survivor immunity, like to call it. Also, because they were doing this zero COVID, they really were not seeing the horrors of COVID in their society. So they also had very low vaccination rates. So here we are asking this simple but important question. Did something intrinsic to the virus change, or are things better thanks to vaccines, pre-existing immunity, the death of the most vulnerable, and improved therapeutics? So we read that with 32,222 COVID-19 hospitalizations and 9,669 deaths confirmed over 6 epidemic waves, the age-specific fatality risk in unvaccinated hospitalized Omicron cases was comparable to the estimates for unvaccinated cases with the ancestral strain. Omicron has comparable intrinsic severity to the ancestral Wuhan strain, although the effective severity is substantially lower in Omicron cases due to vaccination. And I will recommend people take a look at Figure 3. And though not statistically significant, there's actually a trend towards worse outcomes with Omicron versus ancestral. So actually evidence suggesting that rather than the virus getting milder, the virus may have actually gotten a little bit more virulent. But thanks to vaccines and effective therapeutics, things are changing. All right. I care a lot about that for some reason, Sara. Every article I read, they say, well, with the milder strains. I'm like, yeah. Anyway, okay. All right. Bacterial. Be sure to listen to This Week in Microbiology. The Meta-analysis, efficacy and safety of corticosteroid therapy for community-acquired pneumonia, a meta-analysis and meta-regression of randomized controlled trials was published in CID. And here the authors identified 35,713 citations, of which 15 studies and 3,367 patients were eligible for the final analysis. Now, we read that the all-cause mortality at 30 days was significantly lower in the corticosteroid group than in the control group, 6.15% versus 9.06%, a risk ratio of 0.67, and that corticosteroid therapy was not associated with an increased risk of developing any adverse event compared with standard of care. I like figure 2. We get to see a forest plot. And I'm going to say, look at figure 2. Forest plots are key because they tell us if a benefit is consistent or whether there is one big study influencing the conclusion. So looking at the forest plot, it looks like of the 15 included studies, with most having less than 10 events, there's one big study with 400 events influencing the conclusion. We also have 13 studies with no statistically significant benefit and only 2 studies suggesting benefit, and it was impacted mainly by the one big study, the recent New England Journal of Medicine, Sequin et al. Study. So let's look at that one and see what's going on. So Sequin et al. Published the article Hydrocortisone in Severe Community-Acquired Pneumonia in the NEJM back in May 2023, New England Journal of Medicine. Now, that study was a phase 3, multi-center, double-blind, randomized controlled trial where they assigned adults who had been admitted to the intensive care unit for severe community-acquired pneumonia to receive intravenous hydrocortisone, 200 milligrams daily for either 4 or 7 days as determined by clinical improvement, followed by tapering for a total of 8 or 14 days, or to receive placebo. So I just want to point out here that we read our initial study and we're sort of thinking, oh, community-acquired pneumonia, maybe I should throw some steroids. But what really swayed the meta-analysis was really a study of pretty severe ICU sepsis. So just a little bit of a comment there before we start throwing corticosteroids at all our community-acquired pneumonia folks. What do you think, Sarah? Should we start throwing steroids at everybody?
Well, not everyone. Yeah, I agree. I mean, I feel like who you're probably thinking about it is for those sicker patients that are in the hospital and potentially in the ICU. Well, another topic here I have from CID. It's early oral antibiotic switch and Staph aureus bacteremia, the Staph aureus Network Adaptive Platform or SNAP trial early oral switch protocol. So I suspect a lot of people who listen to this are aware of SNAP, but the SNAP trial is hoping for a sample size of 7,000 participants. It is a whole of life trial, meaning they're enrolling neonates through nonagenarians, all ages. It's pragmatic with inclusion of many populations that are often excluded, including pregnant women and people who inject drugs. The early oral switch domain of the SNAP trial assesses oral antibiotics compared to continued IV treatment in clinically stable patients with Staph aureus bacteremia. Their primary endpoint will be 90-day all-cause mortality. Hospitalized patients with Staph aureus bacteremia are going to be assessed at platform day 7 plus or minus 2 for uncomplicated Staph aureus bacteremia, and day 14 plus or minus 2 days for complicated Staph aureus bacteremia to determine their eligibility for randomization to the intervention here, the early oral switch, or continued IV treatment, the current standard of care. This was published on Halloween, and they included some updates that as of August of this year, 21% of all SNAP participants had been randomized to an early oral switch domain. A total of 264 participants across 77 centers with the aim to recruit at least 1,000. The most common reason for non-inclusion of participants at day 7 were inadequate source control or metastatic infection. At day 7, half of the patients had not had what was considered source control, and then that number had shifted to about 20% at day 14. And then the most common reason for exclusion was the criterion, quote, clinician deems not appropriate for EOS, early oral switch. But if you discount those who were ineligible for other reasons, there were only 2% of patients at day 7 and 1% at day 14 that were excluded purely just because a clinician was hesitant. So I know everyone is eagerly awaiting more info on the SNAP trial, so I recommend you at least get a sneak peek at some of the details of the progress so far with this paper.
I was going to say, particularly the nonagenarians. When you're in your 90s, you may not have a lot of time to wait for the results to come out.
Yeah.
All right. Well, this is something our local providers asked me about, so let me include the article, Outbreak of Invasive Group A Streptococcus in Children, Colorado, October 2022-April 2023, published in PIDS. For background, we read, in the fall of 2022, we observed a sharp rise in pediatric invasive Group A streptococcal IGIS hospitalizations in Colorado. We compared the epidemiology, clinical features, and patient outcomes in this outbreak to prior years. So what did they do? So here they prospectively identified almost 100 cases of invasive Group A strep. We read that the median age was 5.7 years old. So these are little kids. And that most of them, 70%, were otherwise perfectly previously healthy. 39% required critical care. 4 of these children died. Almost 60% had associated respiratory viral symptoms. 10% had toxic shock syndrome. 4% had necrotizing fasciitis. There were significantly more cases, about triple the number during the outbreak, including more cases with pneumonia. And I just want to point out, and this is sort of a big thing, not only are we seeing more Group A streptococcus in our children in the visits coming here, but we are also seeing a large number of these isolates resistant to those macrolides. The azithromycin is not doing the trick, and even clindamycin, more than a third of the time, not doing the trick either.
Yeah, and invasive Group A strep is can be pretty terrifying.
Yeah, I worry about it, Sarah, because everyone walks around thinking, oh, I'm allergic to penicillin. My mother was, so I am too. And I don't think people realize what a risky thing it is to falsely carry that allergy.
Yeah. So this next paper is from the New England Journal. And I'm going to say my bias before I even talk about it is that I don't know that I really believe in inhaled antibiotics in most settings, except for maybe cystic fibrosis. So I'm telling you my bias beforehand. The paper is entitled Inhaled Amikacin to Prevent Ventilator-Associated Pneumonia. And so when I am asked as a consultant whether I think a patient with VAP needs inhaled antibiotics, I usually kindly say, probably not, but generally another specialty's opinion, gets weighed in there. And I feel like a lot of patients get started on the inhaled antibiotics. So this was an investigator-initiated, multi-center, double-blind, randomized controlled superiority trial. The acronym is very long. Amikinhal, inhaled amikacin versus placebo to prevent VAP. It's a little clunky.
Yeah, just
for an acronym.
Basically do the title.
Just rolls off the tongue. They assigned adults from 19 ICUs in France on mechanical ventilation for at least 72 hours to receive inhaled amikacin. So this was 20 mg per kg, ideal body weight daily versus a placebo for also 3 days. The primary outcome was the first episode of ventilator-associated pneumonia, or VAP, during the 28 days of follow-up. They had a total of 850 patients who were randomized. 847 were included in the analyses, with 417 in the amikacin group and 430 in the placebo. The groups received the inhaled treatment about the same. So 81% of patients in the amikacin group got all 3 daily nabs, 78% in the placebo group. At 28 days, VAP had developed in 15% of patients in the amikacin group and 22% in the placebo group. These episodes occurred a median of 10 days after randomization in the amikacin group versus 9 in the placebo. So the difference in restricted mean survival time to VAP, 1.5 days, 95% confidence interval 0.6 to 2.6. P-value is 0.004. Infection-related vent-associated complications occurred in 18% in the amikacin group and 26% in the placebo group. So that is, worsening O2, signs of infections, they get new antibiotics. So that hazard ratio is 0.66, and the 95% confidence interval is 0.5 to 0.89. So the conclusions were that, 3 days of inhaled amikacin reduced the risk for ventilator-associated events, including VAP. A couple sort of digging into the details and looking at it, about 14% of the placebo group had an amikacin susceptible gram-negative versus 7% in the amikacin group. Only 2% had adverse effects, which actually was maybe a little lower than I would have thought. It wasn't really powered to link these conclusions to death or length of stay. The mortality was about 30% in both groups. And the question of whether or not this drives antimicrobial resistance is, not really something we can answer with this paper. So I guess my take home is if I am forced to comment on inhaled antibiotics now, I could at least use this study to say, can we limit it to 3 days? I just still am not convinced that this should be routine practice. I don't know what you think, Daniel, about inhaled antibiotics, but I guess I'm just not a fan.
Yeah, no, it's tough, Sarah, because so much in medicine, particularly with inhaled aminoglycosides, is not evidence-based. And it's always interesting when people are doing stuff, but we don't necessarily have the mechanism to say in so many of these centers, like, okay, if you're going to do that, let's do it in a way that we can find out if you're helping or hurting patients. I think we learned in the pandemic, a lot of what we think is helpful is harmful. And so, okay, I see this here. This looks a little bit encouraging, certainly on board with cystic fibrosis. But exactly. I would like better, more robust data to help guide this intervention.
Yeah, for the routine patient who has a VAP, which I think is a different patient than someone who has cystic fibrosis and exacerbation and respiratory failure. Well, moving on. In JPIDS, this one's pretty quick. I pulled a paper assessing risk of complications in acute hematogenous osteomyelitis in children, validation of 2 predictive scores. So this paper was a retrospective study of a little over 400 children at Texas Children's Hospital with acute osteo, and it analyzed the performance of 2 scores, so A score and C score. So the A score predicts risk for acute complications, hence the A. So treatment failure, prolonged admission, plus or minus the need for 2 or more bone debridements. The C score is intended to predict chronic complications, so growth restriction, pathologic fractures, chronic osteo, avascular necrosis, and joint deformity. And so for a little bit more info on these scores, which I actually had not used before, the A score accounts for presence of bone abscess, so you get 2 points for that. Fever after 48 hours of antibiotic therapy, you would get 2 points. Concomitant suppurative arthritis, you'd get 3 points. Disseminated disease, 4 points. Delayed source control, 4 points. So the cutoff of 4 points is positive. So if you have disseminated disease or delayed source control, you automatically sort of score there. And then for C score, they give you a point for a CRP greater than 10 milligrams per deciliter 2 to 4 days after starting antibiotics, or if you have disseminated disease, and you get 2 points for undergoing bone debridement, and there's a cutoff of 3 points. So they found that the A score had a 78% specificity and a negative predictive value of 92% with a sensitivity of 81%. And then the C score performed with 64% sensitivity, negative predictive value 94%, specificity of 86%. So just a little insight into these scores, which was a learning for me because I had not used these before.
All right. The article Empirical Antibiotic therapy in diabetic foot ulcer infection increases hospitalization, was published in Open Forum Infectious Disease. Here, the investigators looked at 147 outpatients with infected DFUs, diabetic foot ulcers, and ultimately included 116. Infections were categorized as mild 68%, moderate 26%, and severe 6%. They compared those getting empiric antibiotics versus those that received culture-based antibiotics. The relative risk for hospitalization was 1.87 greater in those with mild infections when treated with empirical antibiotics compared with culture-directed antibiotics. So regardless of disease severity, when treating your DFUs, your diabetic foot ulcer infections, it is currently recommended to obtain a deep tissue culture to guide that antimicrobial therapy. The use of a superficial swab for microbial evaluation is discouraged by the IDSA and the IWGDF. So get a good swab and use it for guidance.
I have another paper from JPIDS. We're kind of on a bone foot theme, I think. Clinical Practice Guideline from PIDS and IDSA, the 2023 Guideline on Diagnosis and Management of Acute Bacterial Arthritis in Pediatrics. So I'm just going to summarize, which hopefully most of us are doing sort of these practices already, but they're recommendations for evaluation, getting blood cultures prior to antibiotics, potentially using CRP. They recommend against procalcitonin. Recommend getting plain films of the affected joint and adjacent bones, potentially an ultrasound of the joint, and then an MRI if needed. And then getting synovial fluid pre-antibiotics if possible to send for cell count diff and cultures. So this is all very similar to what we think about for the acute hematologous osteo guidelines for kids that came out, I guess it was probably last year, maybe it was 2 years ago. And they make some comments in there about, of course, trying to hold antibiotics until the initial joint aspirate, if it's possible, if the patient's stable. And so for empiric therapy, making sure that you select a regimen active against Staph aureus, which is the most common cause. But remember that if you have a child that is younger, so infants and preschool aged kids between about 6 months and 38 months, they do suggest including coverage for Kingella in your empiric therapy regimen rather than Staph aureus alone. And then sort of moving forward in their care, if they don't have a adequate or expected response within about 2 days or so, to get an MRI and make sure you have good source control. The authors recommend against routine use of intra-articular antibiotics and adjunctive steroid therapy. And then they recommend transition to oral antibiotics in children who are getting better and ready for discharge over OPAT. So confirmed primary acute bacterial arthritis without osteomyelitis, they recommend 10 to 14 days total. So that's counting your IV and the oral that you're going to send them out on. And hopefully moving us away from these longer courses of 3 to 4 weeks, which I think historically has been a duration that a lot of people would have chosen.
All right, the article, The Natural History of Antibiotic-Treated Lower Limb Cellulitis, Analysis of Data Extracted from a Multi-Center Clinical Trial, recently published in Open Forum Infectious Disease. And I do think there's a bit to learn here. I feel like this goes a little bit against what I was taught, which it's always good to keep learning. Here they looked at data from 247 individuals with mild to moderate unilateral lower limb cellulitis who attended at least one face-to-face interview following recruitment. Although there was a local improvement in swelling, warmth, erythema, and pain by day 5 compared with baseline, some individuals still had evidence of local inflammation at 10 days. Here's a couple of things. Most biomarkers demonstrated a return to normal by day 3. So here is the challenge, and the authors first present the background. It's been suggested that approximately 20% of individuals with cellulitis, quote-unquote, fail initial antimicrobial therapy and are prescribed repeated courses of antimicrobials or re-attend healthcare. The authors suggest that it is likely that a proportion of these individuals simply have slowly resolving symptoms, and that these quote-unquote failures represent the natural history of disease. This is also complicated by guidance suggesting reevaluation of individuals with cellulitis at 48 to 72 hours, leading to an assumption that patients should be improving at this point. They look at a number of hematological and biochemical parameters that suggest routinely stabilize by day 3, despite the appearance of failure, and suggest that first, clinicians and patients should expect a prolonged symptomatology, and early reassessment should be considered only in light of worsening, not ongoing symptoms. Second, the use of rescue antimicrobials should again be limited to those with worsening symptoms. They conclude by saying clinicians can use these data to reassure themselves and their patients that ongoing local symptoms and signs after completion of antibiotic therapy do not indicate treatment failure or warrant extension of the initial antibiotic treatment or a change in antibiotic class or mode of administration.
Next, from MMWR, I pulled a vital signs, missed opportunities for preventing congenital syphilis, US 2022. I feel like we've definitely talked about this on Puscast, but hopefully everyone knows that cases of congenital syphilis have been increasing. The reported cases have increased by 755% since about 2012. Again, 700%. So to identify missed prevention opportunities among congenital syphilis associated pregnancies, they created a framework of risk factors. So these included no documented testing or non-timely testing, late identification of seroconversion during pregnancy, no treatment or non-documented treatment, inadequate treatment, clinical evidence of congenital syphilis despite documentation of adequate maternal treatment, and insufficient data to identify a missed prevention opportunity. In 2022, a total of 3,761 congenital cases were reported, including 231 or 6% of these cases that were stillbirth. Lack of timely testing and adequate treatment contributed to almost 90% of congenital syphilis cases in the US. And this was really across all regions, across demographic groups. They found that birth parents of 88% had received either no or non-timely testing. And among the 58% of cases who did have timely testing and did not have an issue with late identification, 40% had documentation of inadequate treatment in pregnancy, nearly 20% received no or had non-documented treatment, with a 12% remaining receiving adequate treatment. So just something to remind everyone about this. I'm sure for those who are Peds and Peds ID, I feel like we have that page of the Red Book. It just like the book naturally falls open because we're getting so many calls about how to interpret this and make sure that we capture these moms and these babies and get them on appropriate treatment.
Yeah, no, this is heartbreaking. I'm going to little shout out for this when we do our clinical update. I mean, look at this, over 230 babies, right? They're losing. And then what was striking too is even when the children are born because of failure to treatment, there were 50 deaths just in 2022. Yeah. So we really, these are preventable. So
yeah, exactly.
All right, I appreciate you bringing that up. All right, moving into fungal. When is the new season coming out of The Last of Us? Well, the article, Diverse Clinical Manifestations and Challenges of Mucormycosis Insights from Serial Cases, was recently published in Open Forum Infectious Disease. And I should remind you, Sarah, just because the COVID is negative, don't forget to test for TB. All right, here the authors describe 5 cases of mucormycosis seen in Texas. They highlight the discovery of a newly identified Apophysomyces species and the consistent increase in the number of cases over the past decades, suggesting a connection with DM, diabetes mellitus, the increasing use of immunosuppression, as well as the surge with COVID-19. All right, moving into parasitic. And we've got a couple cases here. Be sure to listen to This Week in Parasitism, where we will do a deeper dive into both of these articles. The first article, Malaria, was recently published in The Lancet. This is a great article. It's a great review. It's a great intro. Really a big wake-up call to let everyone know that malaria is surging in many African and South American countries, exacerbated by COVID-19 related health service disruption. In 2021, there were an estimated 247 million malaria cases and 619,000 deaths in 84 endemic countries. Also, I should point out, as they point out, Plasmodium falciparum strains partially resistant to artemisinins are entrenched in the greater Mekong region and have emerged in Africa, while Anopheles mosquito vectors continue to evolve physiological and behavioral resistance to insecticides. Fortunately, this paper is behind a paywall, which makes zero sense to make. We also have a article, Clinical Characteristics and Outcomes of Chagas Disease, United States, a multi-center retrospective analysis published in the American Journal of Tropical Medicine and Hygiene. For background, we read that Chagas disease affects approximately 300,000 patients in the United States. And here we learn from a U.S.-based, multi-center, population-based retrospective cohort study looking at the clinical characteristics and outcomes of chronic Chagas disease in 19,831 patients with confirmed Chagas from 31 U.S. medical centers. The positive proportion for those tested was 2.2% up to 4.6% among Hispanics. Cardiomyopathy risk reached an annual rate of 1.3% during the initial 5 years of follow-up among patients with the indeterminate form. So I should mention that. 2 forms of chronic, the indeterminate where they test positive, but they really haven't declared if they'll go on to the determinate form where they have cardiomyopathy. They found no new events for pulmonary embolism, sudden death, or left ventricular aneurysms at 5 years. Learn a lot about ventricular aneurysms in our studies, but not seeing a lot here. Annual risk for arrhythmias and stroke for chronic Chagas cardiomyopathy were 1.6% and 0.8% respectively. Not seeing much data on the gastrointestinal form here, but the yearly mortality and hospitalization rates were 2.7% and 17.1% respectively. Now, here was what really caught me. Only 13 patients had a documented anti-trypanosomal therapy course within 6 months after diagnosis. We are looking at 19,831, and what was that number? 13. Of those that received treatment, 10 patients received benzodiazepine, and 3 got nifurtimox.
All right, and I think I'm rounding us out with our miscellaneous ones. I grabbed a couple. The first one is from JAMA Network Open, Direct Gloving versus Hand Hygiene Before Donning Gloves and Adherence to Hospital Infection Control Practices, a cluster randomized clinical trial. So the question, does direct gloving compared to performing hand hygiene before donning non-sterile gloves influence adherence to infection prevention practices amongst healthcare professionals? So this was a mixed method, multi-center cluster randomized trial. There were 3,790 healthcare workers across 13 hospitals of 4 academic centers in Baltimore and Iowa City. They were assigned to direct gloving, so you don't do hand hygiene before, versus usual care, which is hand hygiene, and then you throw on your non-sterile gloves. This actually included a variety of clinical settings, ICUs, general pediatrics wards, emergency departments, and hemodialysis units. The study demonstrated statistically significant 46% increase in adherence to direct gloving strategy versus the usual care of hand hygiene before donning gloves, 87% versus 41%. Other pieces here included acceptance by the healthcare professionals that it didn't seem to increase bacterial contamination of the gloves in most clinical areas, except they noted, in the emergency room, the hand hygiene rates were low, so maybe not in that setting. But I pulled a a little quote from this paper. Prior studies have found that performing hand hygiene before donning gloves took an additional 32 to 46 seconds compared with directly donning gloves, presumably because healthcare professionals have to wait for their hands to dry before donning new gloves. And additionally, at least one report indicates that healthcare professionals may not believe that hand hygiene before donning non-sterile gloves is a scientifically necessary step, but is rather a matter of guideline adherence. This belief is perhaps due to the disconnect between guideline recommendations and underlying supporting evidence. So very interesting paper, and I think has opened up some conversations amongst those of us in ID and infection control. And then these last two are fairly quick. I wanted to mention a article from Transplant ID, How I Approach Diarrhea in Hematologic Transplant Patients. It's a really nice overview of the topic. It has even a potential testing algorithm. But I actually mostly want to point out Kathy's artistry in Figure 1. Kathy's an ID fellow at University of Nebraska and has awesome medical illustration and graphic skills. So I recommend people can find her on Twitter at Doc Scribbles, and she's done some of the Core IM graphics, and it was just really cool to see a transplant ID oriented one. So shout out to Kathy. And then I will end with a commentary from JPIDS, Averting a Crisis, Innovating Pediatric Infectious Diseases Recruitment and Training, a topic I obviously care about a lot, and a reminder that the pediatric ID fellowship fill rate is 50%. Half of the spots do not fill. So this does give a quick introduction into the current landscape, including the fact that our already limited pool of peds ID physicians is going to be even more limited when you specifically think about patient care, where we really need more people around to do clinical work. And I think this gap is just going to widen in the coming years as particularly as people are retiring and we just have less people coming into the field. So they do talk about some of the current or possible items that are really cool efforts from PIDS, like in the PIDS Foundation. So there's the Summers Research Scholars, and there's a program called Meet ID, where it sort of sponsors trainees to come to conferences and have some mentorship. And, always addresses the question of if we should have a mandatory ID rotation. But I think something that's interesting and is a current topic of conversation is whether or not we should shorten the training duration for pediatric ID. So for those who aren't pediatric, the fellowship is 3 years, and it's always 3 years. It's not like adult where occasionally people will just go through and do 2 years before being able to move towards finding a position and starting their job. So it's interesting to see people's reactions to whether or not we should incorporate that or not. And I think that's also impacted a lot by the fact that on the pediatric side, there's the Pediatric Hospital Medicine Fellowship. So anyway, it's just a nice introduction. And I look forward to seeing how we move forward, thinking about whether or not we can have pediatric ID fellows just do 2 years of fellowship instead of 3. That's all I got. That brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
Our growing multimedia empire. And you can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. And if you like what we do, or you just want us to keep doing it, consider supporting the science shows at Microbe TV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can occasionally find me on Twitter/X, but not consistently, at swindong and at Febrile Podcast. Or if you really want to find me at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.